Hello, good evening. Thank you so much for spending your Wednesday afternoon, evening with us. I am your moderator, Brandon Hooks. I am a pulmonary and critical care physician at Ascension Borges in Kalamazoo. I also am the lead for our pulmonary embolism response team and our pulmonary embolism follow-up clinic. I share a great privilege to be a chair of the communications committee and subcommittees within the consortium. I want to welcome you tonight. This is a fantastic talk, and it's going to parallel and continue the webinar series with the University of Michigan focusing on PE. For those of you that are joining us for the first time, this is a CME event, and it occurs every third Wednesday of each month between 6 and 7 p.m. To actually collect your CME, what you need to do is register with the link provided here and scan the CR code for redeeming your credits. What I want to do is encourage everybody that is on this webinar attending today to actually use the chat box, which is located on the right hand, and encourage you to engage in dialogue and discussion throughout the talks today. And this will be something that we will revisit at the end of the talks. It is such an honor, as I mentioned, to be here moderating with a great group of panelists and speakers that we have. We have Jeff Barnes, who is the Assistant Professor of Internal Medicine in Vascular and Cardiovascular Medicine, Director of the Vascular Medicine Fellowship. He is the holder of the James Wallacroft Early Career Endowment Award at University of Michigan Cardiovascular Center. He doesn't need any introduction. He is such a great speaker in the field. We also have Neha, who is a pharmacist specialist in ambulatory cardiology and anticoagulation medicine, and adjunct clinical professor at the University of Michigan College of Pharmacy. I'd like to also welcome Sierra Higab, who is the Associate Director of the Pulmonary Hypertension and Director of the Pulmonary Embolism Response Team at Henry Ford Hospital in the Division of Pulmonary and Critical Care. Today's course objectives are really going to focus on understanding the role of the Pulmonary Embolism Response Team and the Pulmonary Embolism Clinic, really stratifying these patients, when to appropriately see them in intervals, updating our current guidelines and understanding of management of these patients, as well as highlighting key areas that we need to focus on to optimize medical care. I'd like to actually hand over the screen to our first presenter, Jeff Barnes, to speak more about the role in pulmonary embolism. Thank you, Jeff.
Brandon, thank you so much. That was a wonderful introduction, and it's really an honor to be here and to get to speak with two really wonderful colleagues and friends, both Nee and Sarah. So this is going to be a great session this evening, and I appreciate you and Vikas helping to organize this. I'm going to start us off and try and get a bit of an overview about the follow-up of patients with PE, sort of from the time you're getting ready to leave the hospital through those first couple months and what we should be thinking about. I think Nee and Sarah are going to go into a little bit more detail. So I'm going to sort of set the stage for everyone. I do have a few disclosures that are important to know. They largely relate to companies that make anticoagulants or ways to manage anticoagulation and do have roles with various anticoagulation organizations. I want everyone to really draw their attention to this paper. This was a wonderful paper that just came out in the European Heart Journal. This is sort of an expert consensus recommendation on how we should be approaching those first several months for patients who have acute PE. And I think it's especially relevant for our discussion tonight as we think about the dedicated post-PE clinic and what we do. I'm going to use this as a template to walk through. I can't cover all of this. Nee and Sarah will go into some more details in other areas, but I'm going to highlight a few things that you can think about and how you can draw from this document as you structure your own acute PE program, both in the hospital and importantly, what you do when you leave the hospital. The first time point that's shown here in this figure is what should we be doing at diagnosis? Sort of when the person is in the hospital with that acute PE, what things do we need to be thinking about? And I'm going to focus on two of them. One is, how do we think about managing their bleeding risk, especially as it pertains to anticoagulant selection? And number two, how do we think about treatment of PE in women? What factors may be unique or different that we have to be considering? This is another paper I want to draw your attention to. This is a wonderful review that was led by one of my and me's colleagues, Liza Renner. She's also one of our pharmacists in the anticoagulation clinic. And it lays out the approach to anticoagulation care for patients who have DVT or PE. Importantly, what you'll see here is that there are 3 phases of treatment. So if we think about at the time of diagnosis, we have this initial management phase. This is sort of those first 5 to even 21 days of treatment when we think about which anticoagulant we might want to give a patient. Now, often we're used to giving people parenteral anticoagulants, unfractionated heparin, or even low molecular weight heparin in the hospital. And we may use that to transition to warfarin. That's sort of our tried and true strategy that you can see across the bottom of the screen here. But because we now have access to oral only medications, we can often either avoid or shorten the course of the parenteral anticoagulant we give and quickly get somebody over to either rivaroxaban or apixaban. And what you'll notice is both of them are given at higher total daily doses in that first 7 to 21 days. So as you're thinking about creating your program, you want to make sure that your hospitalists, your ER docs, whoever's caring for the person in the hospital is familiar with these medications and these unique dosing approaches. Now, one of the questions that I often get, and it's important for any PERT program to think about, is should patients get an oral or a parenteral anticoagulant? And how do you make that decision? You know, if we're admitting somebody to the hospital, it's pretty commonplace that we're going to start with a parenteral agent. And I would encourage you to think about using low molecular weight heparin, even preferentially over unfractionated heparin for those first 1 to 2 days. Let's make sure this patient is stable, but let's also make sure they get very predictable, rapid onset anticoagulation that's unlikely to go super therapeutic and therefore could avoid some bleeding complications. If that person does need a procedure, we now have some growing evidence that we can safely do PE-related procedures because they're venous access. We can do them even if somebody has gotten low molecular weight heparin. So work with your interventional colleagues to come up with a protocol that works well. Now, when it's time to transition to an oral agent, I strongly recommend considering either apixaban or rivaroxaban because they're going to give you flexibility throughout the course of treatment. And I would strongly encourage you to use these starter packs. Otherwise, the dosing gets very complicated. There's lots of opportunities for errors in the prescription you write and in the way patients take them. So write for an apixaban starter pack, as you may see on the right side of the screen, or a rivaroxaban starter pack, as you would see on the left side of the screen. And it makes it much simpler for patients to know which pills they're getting, how often to take it based on different days of the week. Now, if they're not eligible for one of these drugs, then warfarin would be your go-to, and you're going to do a low molecular weight heparin bridge while that warfarin becomes therapeutic. Now, what's a special consideration in some of our young women? I always want to ask them about any potential for pregnancy because we know that direct oral anticoagulants are contraindicated in patients who could become pregnant. Now, warfarin is also not a great choice if they're going to require more than 5 milligrams a day. So therefore, we tend to stick with low molecular weight heparin. It's also very important in any woman who could potentially become pregnant, when you start her on an anticoagulant, you talk about contraception options because we would not want somebody to become pregnant unexpectedly while being on an anticoagulant if we can avoid that. I often get questions about breastfeeding and are there concerns there? We have seen some data where the direct oral anticoagulants could be found in breast milk. It tends to be a little bit higher with apixaban than with rivaroxaban or dabigatran. And so thinking about which ones are safest to use, work with your pharmacist to make sure you're making a good selection. And what about oral contraceptive pills? There's sort of this teaching many of us learned in our medical school or our NP, PA schools, that if somebody has an estrogen-containing contraceptive, that must be stopped when they have a PE. Well, that's not quite true. If they really need to be on estrogen, you can have them on estrogen as long as they're taking a reliable anticoagulant. Yet I find most patients would do just fine if we transition them from a combination oral contraceptive over to a progestin-only contraceptive, in which case then they don't have an increased risk of venous thromboembolism and they may not need long-term treatment with anticoagulation. We also get a lot of questions about thrombophilia testing. Should that be done at the time a PE is initially diagnosed? And the answer is no. It rarely changes management, and many of these tests are highly unreliable in the setting of an acute thrombus. But there are certain times where I will consider it, such as my young patients, those less than 50 to 55, especially if they have a history of pregnancy losses or prior arterial or venous thrombotic events, and if they have any history of lupus, because I'm concerned about the potential for lupus anticoagulant and the antiphospholipid antibody syndrome. So what I will test in the acute setting would be a beta-2 glycoprotein and a cardiolipin antibody, but not the lupus anticoagulant if they're on anticoagulation. It's not quite accurate. If I see one or two of those that are positive, it's going to raise my antennas to say this could be an antiphospholipid antibody patient. I may want to think about using warfarin as my preferential anticoagulant until I can confirm that diagnosis down the line. I also get questions about IVC filters and what do we do if somebody can't be anticoagulated? Well, thankfully, we have some fairly recent guidelines from the Society of Interventional Radiology that say if there's an acute PE and a contraindication to anticoagulation, that's a great place to use an IVC filter. If they're undergoing anticoagulation, and if they undergo anticoagulation for that acute VTE and then a contraindication develops, that's also a good time to think about the IVC filter. But if we have somebody who has recurrent VTE on anticoagulation, or even if they are getting advanced therapies, most of the time we could probably avoid a filter. So we really want to be highly selective about who we are giving filters to. Okay, so now let's say you've moved from that initial hospitalization and now you're thinking about that immediate follow-up. And what do you in your clinic need to be thinking about? And again, it's some of these same things. How do we think about managing bleeding risk? What are the special considerations for women? And is there any thrombophilia considerations we need to work up? And what we tend to do here at the University of Michigan, and I think others have similar but somewhat different protocols, we encourage a follow-up with the primary care doc within the first week or two. Let's make sure that patient gets back in touch with the healthcare provider who knows them the best. We also make sure they have a follow-up in our dedicated clinic within 4 to 8 weeks so that we can help to address any of these medium range to long range issues. And I'll get into some of those in the next few slides. We're going to ask about medication issues. Are they taking it correctly? Have they figured out those dose adjustments that happen if they're using the oral strategies? Is there a cost burden and maybe they're not going to be able to get that refill because they got a prescription assistance? And how are we going to address that? Have they had any issues with bleeding? And what can we do? If they've had any vaginal bleeding, let's get them in touch with GYN so we can make sure that we're addressing the source of bleeding and we don't just give up on anticoagulation without exploring other options. And of course, if they were not anticoagulated, but an IVC filter was placed, has the reason for their bleeding resolved? Could we consider starting anticoagulation now so we can think about getting that filter out later? Those are really great questions to ask in those first couple weeks. Going back to our dosing strategy, we now have transitioned from that initial higher dose into our standard treatment doses. So most of the time that's 20 milligrams of rivaroxaban once a day, 5 milligrams of apixaban twice a day. But you could also use dabigatran, edoxaban, or warfarin in these cases. Now, 3 months is a really important time to be seeing these patients and making sure that you're addressing the sort of follow-up from the acute treatment phase and figuring out who needs long-term treatment. And in this case, it's also a great time to decide, should they stay on standard dose treatment or could we even reduce their dose? Again, one of the reasons I like to use either rivaroxaban or apixaban is that at this 3 to 6 month mark, if I'm going to continue therapy, I often can reduce the dose in half. And many patients just psychologically feel like this is a better strategy for long-term therapy. They feel like they may be at lower risk of bleeding complications. The trials didn't necessarily show differences in bleeding outcomes, but many patients feel that that's helpful for them and helps them stay adherent and persistent to these medications long-term, which we know is an important. How do we decide who gets short versus who gets long-term therapy? Again, going back to that review article, we have this nice table in here. Look for the reasons they initially had their clot. Was this a surgical or a transient risk factor? 3 months is probably enough for that patient, and then you can stop. Were there persistent risk factors that exist, such as male sex, obesity, immobility, varicose veins, you name it? Those are patients at moderate risk, and we may want to think about giving them longer-term anticoagulation. And of course, if we can't figure out why they had it, they probably are going to need longer-term therapy. And you can see in the yellow box in the lower right-hand corner how the variable risks of recurrence play out into when we would consider giving them longer or secondary phase anticoagulation or not. I also want to make this point, and this is something I talk to people about all the time. It's not about how long you treat somebody, it's about whether or not you treat them with an anticoagulant. This was a trial where all patients received 6 months of anticoagulation, then they were randomized to placebo or to continue for 18 more months. The yellow line placebo immediately start having recurrent events, but the blue line where they continued anticoagulation, no more events while they were on warfarin. But even at the 2-year mark, when that warfarin group finally stopped their treatment, as soon as they stopped, they immediately began having recurrent events, almost catching up to the placebo group. So it's not about going 6 months or a year or 2 years and thinking that will solve the problem. It's really a question of, should I be on anticoagulation, or is my recurrence risk low enough, or my bleeding risk high enough that I need to stop anticoagulation? And that's the question to ask yourself. Again, if the patient got an IVC filter and they're now anticoagulated with no bleeding, this is the time to arrange filter removal. Another important aspect of your follow-up clinic to make sure you have structure to be following these patients and removing these retrievable filters when possible. And then thrombophilia testing. This is the next time to be thinking about this. You finish that initial 3 months of therapy, the acute clot should have been taken care of. Now is the time to say, do I need thrombophilia testing? And most patients don't, but you might consider it in your younger patients or those with strong family history, or maybe if it has implications for other people in the family. Make sure you're ordering your tests selectively. Please don't just blanket order a panel. Know what tests you're ordering and know how to interpret those tests. And if you're not familiar with it, ask for help. And you need to actually hold the anticoagulant to perform many of these tests, like the protein C, protein S, lupus anticoagulant, activated protein C resistance, antithrombin 3 activity. All of these tests are not accurate when they're on an anticoagulant. So you need to be really careful about how and when you order these tests. But if somebody has previously had thrombophilia testing, you don't need to repeat the genetic test. People's factor V is not going to change from what they had a couple years ago until now. So look to see what's already been done and let's try to not repeat it. And there's really no role for homocysteine testing. That's just not an appropriate thrombophilia for us to be working up in venous thromboembolism. So if I want to summarize and sort of set the stage for what you're going to hear in the next 2 talks, think about assessing and reassessing bleeding risk so that you're making sure you're making the right anticoagulant selection, knowing that many, and I would actually argue most patients are now getting long-term or secondary phase anticoagulation therapy. I tend to use the direct oral anticoagulants as my first line whenever possible, but you have to ensure they're on the correct dose, they're taking the medication, they have access to it, there's not cost burdens, things like that. And think about using that starter pack of either apixaban or rivaroxaban for the first month. That'll really help you out. There's a very limited role for IVC filters, but when they go in, you need to track those patients carefully so that you know when to remove them. And I would argue there's a very limited, but there is sometimes a selectively appropriate role for thrombophilia testing in many of these patients. So with that, Brandon, I think I'm going to stop and perhaps we can turn it over to the next talk. Is that great?
Yeah, that sounds great, Jeff. Thank you. Excuse me. Thank you so much for that talk. That was wonderful as always. You do such a fantastic job with speaking and giving us clinical pearls on a very important area. Next, I'd like to introduce Ni Ha, and I open the table to you, Ni. While we're using this moment, while he's loading up his presentation, I just want to encourage everybody that's on the Zoom today to feel free to use our chat box. We encourage questions. We want this to be a dialogue between you and the speakers. And I may be, asking some questions during the talks as well. Ni, the floor is yours.
Great, thanks. Thank you for having me. So today I'll kind of describe the care model across transitional care, so inpatient to outpatient. So we'll start with inpatient. From a pharmacist standpoint, we play a crucial role in helping the team select and initiate therapy for patient diagnosed with pulmonary embolism. My first line therapy, like Jeff, I would agree with Jeff, is DOAC therapy, unless the patient have any contraindication or if cost is a barrier to therapy. I've listed a couple contraindication here. Drug-drug interactions. My main concern here is patient on inducers, which I will cover in subsequent slides, but that reduces the effectiveness of DOAC therapy. Patient with mechanical heart valve, patient with severe hepatic impairment. When I say hepatic impairment, I would think about patient with a cirrhosis diagnosis, Child-Pugh B and C for rivaroxaban, Child-Pugh C for apixaban. Patient who are pregnant or lactating, and patient who are on dialysis or have creatinine clearance less than 15 milliliters per minute. There are more and more data for the use of DOAC in patient with BMI greater than 40. These data are tends to be retrospective and or include meta-analysis, but essentially showing equal effectiveness in terms of and safety for patients with BMI greater than 40 compared to those with BMI less than 40, as well as patient on a DOAC versus patient on warfarin with Lovenox therapy. So just to expand on the drug-drug interaction component, I would advise that, really focus on the alerts that shows up in the EMR when ordering a DOAC. I know alert fatigue is a very real thing, but I think when ordering such high-risk medication, it's really important to pay attention to these alerts. If you expand on any of the alerts when you're ordering it, it will give you a description of what the drug-drug interaction is, as well as potential management options for dealing with those drug-drug interactions. Sometimes it can be very complex in that there are many drug-drug interactions and not just a single one. And in those situations, definitely consult a pharmacist to review, all the various interactions. I'll also plug two useful organization with great resources that you can refer to. So one is MACI, which is the Michigan Anticoagulation Quality Improvement Initiative, as well as the Anticoagulation Forum. I've added links to both of these resources. They're great resources in terms of updated in product and guidelines, as well as useful handout for various management of anticoagulation therapy. The screenshot here is just an example of resources on how to manage drug-drug interaction in patient on Xarelto or on rivaroxaban and apixaban. So going deeper, these are the ones that I am very concerned about. So the dual inducers. So these are strong inducers that reduces the levels of DOAC in patient's system, which would make it contraindicated in patient on these medications. In this category, I would think of anti-epileptic medication as well as HIV or medication we use to treat HIV. St. John's wort is a herbal medication that also induces these enzymes. So if you have patients on any of these agents, I would avoid the use of a DOAC. On the opposite side, we should also be aware of strong inhibitors. So these agents tend to increase this level of DOAC in patient's system, which then predispose them to bleeding. And in this category, I would focus on patient on antifungal medication, as well as patient on medication used to treat HIV. In this, if you notice any patient on these type of medication, you have the option to use apixaban with a dose of 50%, but you should avoid the use of rivaroxaban in this category. Another important category is antiplatelet therapy. So if you notice a patient on antiplatelet therapy, make sure that you reevaluate the need for that antiplatelet therapy and eliminate it if at all possible, just to reduce the patient risk for bleeding. And then cost is the other major barrier to DOAC therapy initiation. I would recommend assessing the cost of these therapy even before starting these agents for patients. Most health system has a transitional care technician, most likely within the pharmacy department. Some of the social work department will also have some resources to help you with this situation. So they basically send a test prescription to the insurance just to verify that the cost of these DOACs for a patient. Sometimes this process will trigger a need for a prior authorization, which is also a great time to clear the prior authorization before the patient is discharged. And in certain situations, patient with commercial insurance will have high copay or a high deductible. And in that situation, you can either refer the patient to apply for a patient assistance program through the manufacturer, or the transitional care technician or a social worker can also help patient get resources to reduce the patient's copay. So once you determine the patient has no contraindication for a DOAC and cost is affordable, the next thing is making sure that the patient's on the appropriate dose for a PE. So Jeff had already mentioned, rivaroxaban and apixaban requiring an initial higher dose. And I would agree, if at all possible, definitely utilize a starter pack, just because I think that reduces issues with compliance, as well as any confusion that the patient may have in that transition phase. If you are to start a patient on warfarin therapy, 5 milligrams a day is the standard dose. I would advise a lower dose in patients who are frail or elderly at 2.5 milligrams a day. These patients will require Lovenox or enoxaparin bridging. You have the option to use the 1 milligrams per kilograms every 12 hours, or the 1.5 milligrams per kilograms every 24 hours. I tend to go for the 24-hour dosing just because it's easier for patients, unless there's any contraindication. Some of those would include patient with a mechanical heart valve, patient with active cancer, patient with unstable PE, or patient with a left ventricular assist device. Otherwise, that dose tends to be a little bit easier for patients during the bridging phase. Keep in mind that Lovenox or enoxaparin require dose modification for patient with reduced renal function. The cutoff is less than creatinine clearance, less than 30 milliliters per minute. And that below that cutoff, patients should be on 1 milligrams per kilograms every 24 hours. Some dose adjustment can be considered for patient with obese or a patient with high BMI or in the obese category. This is still institutional specific. Here at Michigan Medicine, we use 0.9 milligrams per kilograms every 12 hours for patient with BMI between 30 and 40, and 0.8 milligrams per kilograms every 12 hours in those with BMI greater than 40. Next part is patient education. Again, a very important component of patient care. Some of the key component of a patient education session should include administration, so how to take the medication appropriately. Again, I want to highlight the starter pack just because it's clearly laid out for patient. It goes through day by day and how much they should take each day. So that really helps with compliance and reduces any confusion in the transition from the initial dose to the maintenance dose. We also cover, how to manage a missed dose for patients. We review signs and symptoms of bleeding that they should be monitoring, as well as how to manage those episodes if one happens to arise. And then other teaching points, include making sure that they contact their provider if there's any changes to the medication, both prescription medication as well as over-the-counter medication, and also to notify their provider of any upcoming procedures that may require assessment for perioperative plan. So now we're at discharge. So here are some of the key components, one of which is providing a patient with an education sheet on the specific drug that they're being discharged on, just so that they have a written resource to refer to once they're home. The main takeaway point of discharge is making sure that there is a written anticoagulation plan that is communicated to both the patient as well as the patient designated outpatient anticoagulation provider. I think that's a very important component of a discharge. And then ensuring that the patient have access to the anticoagulant. So if you're sending a prescription to the local pharmacy, making sure that pharmacy has the medication in stock. This is particularly important for the starter pack, just because not every pharmacy will have a starter pack in stock. And what tends to happen is if they don't have it in stock, the patient will have to wait for the pharmacy to order one, and that introduces gap in therapy at a crucial phase. So just something to think about. If you're discharging a patient on warfarin, make sure that there's a referral in place for someone to pick that patient up in the outpatient setting, either an anticoagulation clinic or a primary care doctor. At the initial visit in the outpatient setting, we'll do a quick assessment of labs and contraindication just to make sure that the therapy is still appropriate and that the dosing is appropriate. If the patient has been on therapy for a few days or a week, just doing a quick assessment on the tolerability, assessing for any signs and symptoms of bleeding, and then making sure that they're transitioning from the initial dose to the maintenance dose appropriately is a key component here. If patient is discharged on warfarin, then we need to also make sure that the enoxaparin is discontinued appropriately once their INR is within goal. And then the outpatient, we also reinforce patient teaching points, just because I think it's a lot of information for patients to take in during the admission. So I think reinforcement is very important in the outpatient setting. At follow-up, we'll reorder labs if necessary to reassess dosing, also assessing for compliance as well as tolerability to therapy, and then providing any educational points if needed. An important point here is also defining the treatment duration, as well as plan to transition to a prophylaxis dose if appropriate. Looking into the future, Jeff plays a crucial part in the initiation of this program, which is the DOAC dashboard, which is basically a live report that we run that captures all patients within the health system on an anticoagulant, and flags us of any patient who may require intervention. So a patient who may have new medication that interact with their DOAC, or patient who may have fluctuation in their renal function that may warrant a dose reduction or a modification. So this is a powerful tool, and that allows us to manage all patients within the health system rather than just patients who are referred to our clinic for management. So I think this is going to be the future of anticoagulation management. So just to wrap up, in the inpatient setting, consult your pharmacist if one is available for therapy selection and dosing. Definitely utilize the drug-drug interaction alert in the EMR. Make sure that the DOAC is affordable for the patient before initiating therapy. Utilize the DOAC starter pack if one is available. At discharge, patients should be provided with patient education on the specific agent. A clear anticoagulation plan should be communicated to both the patient as well as the outpatient anticoagulation provider. And then finally, in the outpatient setting, reassessing the therapy for both appropriateness of dosing as well as tolerability. Reinforcing patient education is important. And then also defining the treatment duration or plan. And that concludes my part of the presentation.
Well, thank you so much, Nee. I think you actually bring a very important point that having a pharmacist involved in your team, in your clinic is definitely an added resource. And the PE clinic is not just, one person, it's a multidisciplinary team that helps with these management decisions. And you pointed out really good information about drug interactions. As we're moving on, I just want to say I like the conversation that we're having in the chat box. I encourage that to continue. There's a lot of good questions that have been asked. And I like to see the representation too from not only Michigan, but the surrounding states and beyond. So we thank you for joining us today. Next, I want to, before I go, I have Sarah Higab. I'm going to give the floor to her, but one thing I do want to highlight and, say to others, just to add on to your point, Nee, is one thing that we strive for here is these transition points when patients are leaving the hospital and in the clinic. And we either try to make sure they have drug in hand, actually have the physical medication with them before they leave. And if they don't, have a reliable pharmacy that's 24 hours and we know that they received it, but also they have the first dose of that medicine to get them through to the following day to obtain that prescription. So those are some points that I do at my institution, which I think are helpful. I'm looking forward to hand over the floor to Dr. Sarah Higab. We cannot see your screen, Sarah.
Okay, I think I'm having trouble with, can you see it now?
No, we're seeing a picture of you.
Yeah, I think I'm having trouble because there's something going on with the screen recording access. I think this should have done it. Just 1 second.
Sure.
Did that work?
We can. What I could actually do is if you sent me your PowerPoint,
Yep.
and I could pull up on mine. And so while we're waiting, I don't want to have dry air. I want to use this as an opportunity to start asking some questions. And what I wanted to do is first I want to ask you, Jeff, in your slide, you were talking about assessing the bleeding risk. And I think that's really important, especially when you have patients that have risk factors that may put them at increased risk for bleeding, and also in particular age and falls. Is there a particular risk stratification that you use, like for example, has bled in these patients to better get a sense of their bleeding risk with anticoagulation?
Yeah, it's a really good question and one I get all the time. And the answer is no, I don't use any of the formal risk scores like has bled or Orbit or Atria or any of those. But what I do is I use them to think about what ways can I maybe mitigate or reduce bleeding risk. And so I will look to say, is this somebody who's on concurrent antiplatelet therapy and could that be stopped? Is this somebody who's taking NSAIDs and can we address that? Is this somebody who has a high degree of alcohol use and can we discuss the implications of that? So I look for some of those things that are addressable. And then of course I look for a history of bleeding, advanced renal failure, liver failure, things like that to say, is this somebody who I'm particularly concerned about and maybe need to keep a closer eye on? But I don't go through and formally calculate these scores, or I don't use a score to determine whether or not to anticoagulate someone.
I mean, that's a great point, because you're not only just looking at who checks the box, you're actually looking at the overall big picture of, not specific things, but the risk. That's really great. So one of the things that is often debated, or something that I hear regarding anticoagulation uses in those patients that are obese, particularly with a weight greater than 150 kilograms and with a BMI that's greater than 40. How do you approach these patients? And do you know if in your clinic, just out of curiosity, do you ever check for factor 10A, or is there any other way that you approach this special population?
I think that's a great question. I'll address the checking levels first. We do not check levels for patients with BMI greater than 40, just because even if you get the results, there's no direct correlation to outcomes or safety. So I call that comfort medicine, right? That you order a level, but it doesn't tell you very much. So I think with the new data, I think that's more reassuring, just because it's actually comparing outcomes in patients with BMI greater than 40 and less than 40. So I think at this point, always it's not always clear. Like if a patient is if it's more convenient for the patient, I would be comfortable using a DOAC in patient with BMI greater than 40.
Yeah, I think you bring up, that was a loaded question, so I didn't want to put you on the spot. Because oftentimes I have people that are chasing, 10A, 10A levels, and it's one of those things that often they have an issue with interpretation, whether or not it's appropriate to use in these patients that are in 10A. So I didn't mean to put you on the spot, but I just, it's a question that's brought up, clinically, that I see often if they've been referred and hand me a 10A level. So it's relevant. I think it's really relevant. Greg Piazza said this in a webinar that, pulmonary embolism is not just an acute disease, it's a chronic disease. And I think this is what we're actually highlighting here today with our pulmonary embolism clinic, is we're not really focusing only on the acute phase, but we're actually following them in several phases. And throughout those phases, we need to really think of it in terms of chronicity. And during those periods of time, we need to identify other things regarding the chronicity, the duration of anticoagulation, and furthermore, additional risk that will put them at probability of recurrence. Scott, I'd love to hear your thoughts.
Well, Brandon, I just wanted to bring up another point, if I may, because we've had some great information here about what needs to happen post-PE. We've talked about, and there've been some great questions about who needs to be seen post-PE. And I think everybody here says everybody needs to be seen post-PE. But I'd love to just ask your thoughts about how one makes that happen within the system. Meaning we know that a PERT, if you have it, can be instrumental here, having things in a discharge summary so that the right patients can be seen by the right people. But I'm curious to know your thoughts about how do we make sure all of these patients are seen by somebody?
So I could actually speak on, my experience, and I'll just say that here's the disclaimer. I practice in a community hospital, and I've actually set up pulmonary embolism response teams and follow-up clinics, and it really it's a labor of love to get it accomplished. And I'll be very honest with that. And it takes a lot of education, especially with discharge planning, case management, hospital involvement, and support. What we do have is basically a set referral pattern within the hospital that people can refer to us directly. And that's in the settings of the emergency department, and also those that we are activated from within the hospital from a PERT call. We always make sure that they have a follow-up with me in a dedicated pulmonary embolism clinic. My approach to it is actually I like to see them within 3 weeks, particularly if they're on Xarelto or other medications, because of a timeline change, so they understand they're not taking 2 medicines, they're going to take 1. And oftentimes I rather catch them to actually refill medicines, and that helps with better compliance, so they don't show up and say, hey doc, I've been without it for two days. But Scott, I think it's a great question. It is a challenge, to do that, but I think it is manageable. Jeff and Scott, from your experience at University of Michigan, how did you address this question, how did you get people to actually return back to the clinic for care?
Yeah, I think there's a couple key things, right? And start small and then grow over time. That would be my advice for anyone who's doing this. One of the things to think about is make it a standard part of your note. So in the very first consult note we drop, which we have a template for, it talks about referral to the PE clinic, and we have a dedicated order so that's easy to do. And then it's word of mouth, right? It's letting people know that you have this service. It's when they refer people, they see that you're taking good care of them, and it starts to grow and people start to say, hey, this is a wonderful resource. Then you can get more fancy. You can start screening or having best practice alerts and other things like that. So I think that there's ways to grow this over time.
Yeah, that's such a great point too. You know, I'm at a community hospital. I'm not fortunate to have a coordinator or resources for that. So publicity has really spread awareness within our hospital institution of our program. We have also done things for VTE awareness in March, which we are heading into, about our PE program and our PE follow-up clinic.
And gentlemen, there's a great question. You know, how do you have your system buy into this? How do you gain support? This is, Jeff spoke to this recently at a grand rounds at our institute at Ohio State recently. I'd love to hear your thoughts again. How do you get buy-in? How do you show that there's a financial benefit, if that's part of it, a QI benefit here?
Yeah, I think there's a number of things that you can address, right? Is there a clinical care piece that's critical, right? Is there a quality measure that you're able to address? Is there a quality of care element? Is there a satisfaction piece? Is there something about the clinician stress or the patient stress that you can sort of point to? And then are there ways to sort of highlight that you're helping to avoid complications down the line, whether it's by having a PERT program and a dedicated follow-up, you can also avoid hospitalization for your low-risk PE. So is it a 2-for-1 sort of situation? And can you make that argument to your institution? So think creatively about how you make that argument. What's valuable to people? Dollars are always valuable, but other things are valuable too, time, quality, and whatnot. And see if you can leverage some of those to get that buy-in.
I would also make the argument that you want to highlight the fact that a lot of these patients don't get care, specialty care at all. So you're going to bring patients into the system. A lot of patients may receive specialty care for advanced thrombectomy or surgeries, or transferred in, and then so you're retaining them in the system, hospitals like that. And then the other thing is, don't forget to highlight sort of the halo effect, the downstream testing and other things. So not to say that that's the reason we do things, but this is the complete care of the patient, and it's going to lead to better long-term outcomes. And if you can demonstrate that, decreased length of stay in the hospital, decreased readmissions, you're going to have something that they're going to be very interested in.
Sanjam, that's a great point. I think when I've had meetings with hospital administration, you know, demonstrating those points as well about reducing the hospital length of stay, having a multidisciplinary group to actually weigh in on the decision for the appropriate care, and actually demonstrating a need, right? These patients are quite complex and they have severities of acuity. So having a dedicated team to actually not only risk stratify them, provide them with advanced therapies if indicated, but also better manage transitions of care.
One other.
Still wait. Oh, I'm sorry, Sanjam.
No, go ahead, Vikas. Go ahead.
Oh, sure. I think we're still waiting for Dr. Higab to get his slides over, but I would make one key point that Jeff championed for us at Michigan is some patients with pulmonary embolism don't need to be admitted, and they could be discharged from the ED itself. If you can arrange for a clinic appointment for them, a rapid access clinic appointment, so within a week, and having that as an option to declutter your hospitals. So when every inpatient and observations bed in the hospital is a premium, is a pretty big incentive. I feel like for the administration, if you're asking for resources, plus it's also great patient care because, you know, nobody wants to be in the hospital if they don't want to be, or they don't have to be. So, just so that point, I'm going to let Sanjam say what he was going to say.
I know I was having a question to the group is, one question that I got asked recently is how long do you follow these patients? And my argument is that I treat it just like I would treat CAD or diabetes or any other sort of illness that a patient has had. I follow them longitudinally long-term because there are factors that may come up. They may have change in their clinical circumstance. A patient who had a PE, the setting of her first pregnancy may have become pregnant again. And then what do you do when the patient has become pregnant again? They've already had a PE. And so these kinds of issues, it's really not one and done, in my opinion. But I want to know what the panel's thoughts are on that.
Sanjam, I think that's a really great point. And this is clearly a chronic illness. I do think, however, that every clinic's going to be a little different, and it's really going to be based on the resources that you have. And if you have the ability to see a large volume of patients in sort of a chronic management setting, then following these patients long-term would be ideal. If, however, you just don't have access to that much clinic space and that large of a panel, you may be limited to only seeing them in that first 3 to 6 months, and then determining, okay, is this somebody for whom I need to make sure they're seeing somebody like Dr. Hagab, who can follow them from a pulmonary hypertension or a chronic thrombo-embolic disease standpoint? Or is this somebody who's really done well, they're stable, and I can get them back to their primary care physician? So I think a lot of it's going to depend on your resource availability. But remembering that PE is a chronic illness is a critical element.
So, Sanjam, what I could say too is, excuse my voice. I tend to think of it the same direction as you, as longitudinally, and thinking found these patients over time. I just want to point out some key statistics with things too, especially in those with unprovoked or no explanation of VTE. There's 10% of the population that have increased risk of malignancies. And so I've often had patients that I follow longitudinally that have developed, cancer. And so, managing them through that. In addition, sometimes patients may have operations or may need to stop anticoagulation. So being ready and proactive is something that they need somebody to continue managing it. I see myself, like the primary care of PE, really focusing in on the whole spectrum of things for them and the management of their, VTE. But that's my my take on it. I'm curious to know if anybody has anything different or would agree.
So one thing I would say, Brandon, is those are excellent points. I agree with you. It seems like Sarah's slides are not going to work tonight, but if everybody's okay, I can show some slides that I have on the same topic, and that way we can cover the chronic complications.
And team, I also sent out what I think is a really provocative article. I sent it to everybody. It's the InShape 2 trial, which looked at, how do you predict who with PE, who's had a PE, might go on to develop CTEPH. Because we can't echo everybody. We can't cath everybody. So please take a look at that. I can't wait to see Sarah's presentation. Hopefully we can do that next time. But Vikas,
I just got her slides, so I think we can do it. It's opening. So.
Oh my gosh, sorry. So sorry I'm not sure what's wrong with my work email, but it would not allow the attachment.
We have it, Sarah. I'm
okay.
I'm opening it right now. I'm so glad we made it. Let me share screen.
So I know we're over time. Do you want me to just kind of highlight the salient points?
Yeah, I hope members that are in attendance right now today could stay a little bit longer. It's a great topic. I think it's really important and relevant.
And we sent the QR code for the CME credits so in the chat box, there is a message from Craig Cornelison, so please use that. Those who are first time users, they would have to make an account. But okay, so I'll move the slides forward for you, Sarah.
All right, very good. Thank you. So these are my disclosures. Next. So the objectives are to talk about post-PE syndrome, really try and define it, review the pathophysiology of CTED and CTEPH, discuss the incidence and risk factors for CTEPH, the diagnosis and treatment, and an overall algorithmic approach to post-PE syndrome. Next. So when we think of post-PE syndrome, many patients after resolution of their PE may go back to their normal functional capacity without any exercise limitation. However, in the past few years, there's been increased recognition that there's a subgroup of patients that may report decreased functional status. They may, a smaller subgroup of those patients may, with testing, prove to have persistent thrombi. Others who undergo CPET testing may show measurable limitations in cardiopulmonary function, and a very small subgroup of these patients may have CTEPH. Next. So when we think of how we define post-PE syndrome, it's suboptimal cardiac function as well as suboptimal PA flow dynamics. We find abnormal gas exchange at rest or with exercise, exercise intolerance, and diminished functional status. Next. So as we move from an acute PE event, typically within 3 months of anticoagulation or 3 months of the acute event, there's resolution and restoration of perfusion. However, there are sometimes factors that will lead to non-resolution of the thrombi that form. Those can be clinical factors such as size of the initial thrombus. So the larger the thrombus, the greater the likelihood that there may be issues with resolution of the clot. RV strain at the time of diagnosis, delay in anticoagulation. There may be impaired fibrinolysis that can result in reduction in that resolution to perfusion. Remodeling of the emboli can happen, that it's mediated through various mediators. And then inflammation plays a role in creating these persistent defects. And they become known as CTEPH when there's associated pulmonary arterial hypertension. So when we define pulmonary hypertension in general is an umbrella term that means that when measured invasively, someone's mean PA pressure is greater than or equal to 20 millimeters mercury. We call it pulmonary arterial hypertension when that pulmonary pressure elevation cannot be attributed to left heart disease, meaning that left-sided filling pressures are normal or below 15. And to mandate that this be an invasive hemodynamic diagnosis, PVR was added to the definition several years ago. So you cannot make this diagnosis without a right heart cath. To call it CTEPH, it's having these hemodynamics in the setting of a VQ scan that shows at least one segmental defect, or imaging or defects on CT scan imaging or pulmonary angiography after at least 3 months of effective anticoagulation. Next. Looking at the top image there, you'll see what a chronic clot looks like. So these are fibrotic, organized thrombo-emboli that are tightly attached to the medial layer of the pulmonary arteries and replace the normal intima. In contrast, you can see the bottom picture is an acute thromboembolus. So this is a very soft, more jelly-like, more friable clot that's much more easily removed. Next. So when we talk a lot about CTEPH, and it's kind of this feared complication of acute PE, but what is the actual incidence? The incidence varies depending on the series that you look at, from anywhere under 1% to up to as high as 9% in some series. But I think the most agreed upon kind of overall incidence comes from the PENGO trial, which really estimated it to be at around 4%. And so if we think of the fact that there are roughly 600,000 acute PEs per year, that puts us at about 24,000 cases of CTEPH per year, which is a conservative estimate because it doesn't actually take into account the 20 to 30% of patients who have confirmed CTEPH who don't actually carry a prior diagnosis of PE. Next. The signs and symptoms tend to be very non-specific, which is true of acute PE and is also true of chronic PE. So dyspnea on exertion, fatigue. In more advanced cases where hemodynamics are kind of more severely affected, patients may get syncope. You'll see signs of right heart failure on physical exam. However, a difference between CTEPH and pulmonary hypertension is that in CTEPH, you'll tend to see hemoptysis, whereas in pulmonary hypertension, that is much less common. And that's due to the bronchial collaterals that form in chronic clot. You may rarely hear bruits over the lung fields. That's due to turbulent blood flow over the proximal occluded pulmonary artery. This can happen in up to 30% of patients. It is not very sensitive, but is highly specific when it's found and not found in IPAH. Next. So once we have someone who has unexplained dyspnea coming to clinic, it is really important to conduct an echocardiogram or order an echocardiogram. So that's really one of the first things that I'll do in patients who I'm seeing in follow-up PERT clinic is you're assessing their symptoms. Once you have an echo, if the echo shows any evidence of RV compromise or pulmonary hypertension, then you should proceed with VQ scan as your screening test for CTEPH. If a patient has a normal echo, that doesn't necessarily mean that they don't have underlying cause for post-PE syndrome. And in order to better elucidate that, you should obtain a cardiopulmonary exercise test. Next. Why do we get a VQ scan is a common question that I get asked in PH clinic. We may have a recent CT or, a patient who had a PE subsequently went on and had another CT scan with contrast, and we have it and we know it doesn't show any large clots or any PEs. So why do we need the VQ scan? The VQ scan is a much more sensitive test for detection of chronic clot. When compared to CT, sensitivity of VQ is about 96 to 97%, whereas CT is around 50%. Now, more recently, with improving CT technology, with increased awareness among radiologists in terms of what signs to look for in CT imaging, CT sensitivity has probably gone up from that, but it is still not that of VQ scan. Next. And so once we get the VQ scan, a VQ scan that is normal essentially rules out CTEPH, and we need to look for other alternative causes of pulmonary hypertension in those patients. However, a mismatch perfusion defect in the setting of elevated pressures on that echo that we initially got really is highly suggestive of CTEPH. And the next step would be to obtain a CTPA. The CTPA in that case will serve several purposes. We may either see very proximal clot located on that CT, and it can serve as a surgical roadmap in that case for an endarterectomy surgeon to determine or to be able to guide surgical intervention. We may find evidence of pulmonary hypertension, but no proximal clot, and that may raise the index of suspicion for more distal disease, in which case more testing in the form of pulmonary angiography is needed so that we can determine whether the segments and subsegments are affected. This will weigh heavily on whether someone may have operable disease or not. And then the other thing is that sometimes we'll find alternative causes for the findings that we're seeing on the VQ scan. So we may see a PA sarcoma, we may see evidence of vasculitis or fibrosing mediastinitis. So those can be mimickers of CTEPH, and that will take us down a completely different diagnostic pathway with other testing indicated in that case. Next. SPECT-CT VQ is kind of a more recent technology where we're combining the CT imaging with VQ imaging, which can give us really nice pictures and road mapping of where our perfusion defects are. Next. And then ultimately, a pulmonary angiogram is performed in all cases that we are evaluating for CTEPH. And as you can see here, there's significantly reduced perfusion in that upper lobe there. Next. Ultimately, our goal is to determine if a patient with CTEPH has operable versus inoperable disease. CTEPH is the only potentially curable cause of pulmonary hypertension, and it is cured with endarterectomy surgery. So our goal is to get patients to surgery whenever possible. If they have small vessel disease or they're deemed to be inappropriate to undergo a large surgery which requires sternotomy, then there may be other treatment options available, and there is an FDA-approved medication called Riociguat that can be used for inoperable CTEPH. Next. What about CTED? So patients with CTED are those who have persistent thrombi. However, they don't have pulmonary hypertension on hemodynamics. And this was a really interesting exercise study that found that patients with CTED actually behaved very similar to those with CTEPH and had many of the same exercise limitations and findings, pathophysiologic findings that you find in CTEPH. So for example, patients with CTED and CTEPH in the first quadrant there had reduced maximum workflow, reduced maximum work. They had lower end-tidal CO2s, which is a finding that is common in pulmonary hypertension. They had decreased overall oxygen consumption, and they had increased dead space ventilation, which is another common feature on exercise testing in patients with pulmonary vascular disease. So while these patients don't have pulmonary hypertension by hemodynamic definition, they certainly do have exercise, they have abnormal exercise testing, which can explain what their functional limitation is resulting from. Next. And so while CTEPH represents, is really this entity that we look for very, very diligently because, again, it's the only potentially curable form of pulmonary hypertension. Post-PE syndrome is a very broad kind of category where patients have exercise limitation due to potentially many different causes. Next. This was a study that looked at patients with PE who were followed for initially 6 months, and everybody who was symptomatic at that 6-month mark got echoes. And what you'll see is that patients who were symptomatic very commonly had diastolic dysfunction that was noted on their echo. So 48% of patients had diastolic dysfunction. Also importantly, not an insignificant number, so 27% had an intermediate probability of pulmonary hypertension. Next. And if you look at those patients who had intermediate probability of PH, who then underwent further evaluation for CTEPH, about 22% of them actually had confirmed CTEPH, with a much smaller proportion of patients having CTED. So this isn't an insignificant number overall, and I think highlights that patients who are persistently symptomatic after PE should undergo further evaluation. It could be CTEPH or CTED, but there could also be other causes, with diastolic dysfunction being the most common finding in this subgroup of patients. Next. And so this is a proposed algorithm for how to best follow patients kind of in this post-PE time period. And so the recommendation is that if a patient has persistent dyspnea at 3 months following an acute PE, they should undergo transthoracic echo as well as workup for other etiologies of dyspnea. If the transthoracic echo is suggestive of pulmonary hypertension, then we go to the left side of our algorithm, and those patients should undergo VQ or SPECT CT. If the VQ is positive, then that's very highly suggestive of pulmonary vascular disease, and those patients should be referred to a PH or CTEPH center where they'll undergo further diagnostic workup and hopefully treatment. If a patient's VQ or SPECT CT is negative, then they should have a right heart cath. And if there's no pulmonary hypertension on cath, then we're looking at non-pulmonary vascular causes of dyspnea in that case. Now, if we go back to our algorithm kind of in the center, and we look at the echo, and the patient undergoes or has a low probability of PH and I can't find anything else to explain why they're having their shortness of breath, it is reasonable to still proceed with a VQ in that case, because what we're looking for is that entity of CTED. We're looking for this subgroup of patients who may have chronic clot, but they don't quite have pulmonary hypertension, but we know may have exercise limitation from these persistent thrombi. If the VQ is positive in that case, then it's reasonable to proceed with cardiopulmonary exercise testing. Now, it doesn't say this in the algorithm here. I think it's reasonable in this case to either undergo kind of non-invasive exercise testing, where patients can sit on a bike and we can assess them non-invasively. There are others, however, if I'm suspicious that there might be exercise-induced pulmonary hypertension, it may be reasonable to do an invasive cardiopulmonary exercise test where the patient does have a right heart cath, in a PA catheter in place while they're exercising, so that we can help determine whether it's diastolic dysfunction, whether it's exercise-induced PH, or whether perhaps they don't have any hemodynamic issues that we can elucidate on cath, and this really is just a case of CTED. And so if that cardiopulmonary exercise testing, whether non-invasive or invasive, is suggestive of pulmonary vascular disease, then again, that patient should be referred to a PH center. If the VQ scan in the setting of a low probability for PH is negative, then this is post-PE related dyspnea, and it's reasonable to consider referral for exercise or pulmonary rehab at that time. And then if all low probability of PH and all other etiologies of dyspnea have dyspnea are suspected, then those should be treated. So for example, if somebody has asthma or COPD or some other underlying comorbidity that is not optimized, or heart failure that is not optimized, then optimizing those would be the mainstay of therapy. Next. And so taking from the graph that, or this figure that Jeff showed in the beginning, if we look at our 3-month mark, kind of that red column, in addition, so post-PE syndrome is a little portion of that, or we focus on it the most, but again, assessing patients' bleeding risk at that time, whether there are any issues with compliance with their medications. I think at the 3 to 6 month mark, it's reasonable to look at IVC filter placement and whether we're thinking that they can be retrieved at some point soon or not, and setting a plan, making sure that a plan in place is in place for that. Next. And so the bottom line is that post-PE syndrome has an impact on patient functionality and quality of life. CTEPH is the only cause of pulmonary arterial hypertension, which is potentially curable by surgery. And it's an pulmonary endarterectomy surgery that involves surgical removal of these obstructing clots. And it's a highly specialized surgery that is technically difficult and is really only performed in a handful of centers across the world. Medical therapy should never delay referral for surgical evaluation when we're talking about CTEPH. And we should always look for other causes of dyspnea. Diastolic dysfunction and lung disease are big culprits. And so we mustn't forget that our patients often have these other comorbidities where there may be an opportunity to optimize therapy. We do need more research on CTED because these patients at this moment in time are not candidates for the same treatments that patients with pulmonary hypertension and CTEPH are. But they clearly have very, very similar exercise limitations on physiologic testing. And patient-reported outcomes and functional outcomes are increasingly important to consider in PE clinical trials. And with that, I'm happy to take any questions. I appreciate your patience, and I appreciate, and I apologize for all of the technical issues in the beginning.
Sarah, fantastic talk. I always learn something from you every time that you speak. I want to thank everybody for staying on the call. I do want to share my screen because I want to make a correction to something here. So I'm going to share my screen if I can. See if you're able to see. So I apologize. The original QR code that we had at the beginning was for the previous meeting that we have. So this is the QR code for today's event. Scan this on your cell phone and it will actually provide you to the link for CME redemption. Hey, before we actually And I have a question that I want to ask for the panelists and also for Dr. Higab. Where and when do you utilize, when you're talking about the CT scan after VQ scans, when do you utilize CT dual energy scan?
So the challenge that I've had with that is, and I think Vikas can also comment on this, because I know that with their CTEF program, I'm sure they come across this a lot. Often, from a resource utilization standpoint, it becomes a problem, or it's challenging to get insurance authorization for it. It's challenging to get it scheduled with the radiology department for some reason. And so we have not utilized it as much as I think we can. But I'm interested to hear what Vikas's experience has been.
You know, we have not, so at least I have not had so issues with insurance authorization for CT angiograms on so in these patients. We do routine CT angiography on everybody that we are evaluating for pulmonary angioplasty or for surgery, but our protocol is largely that if there is a VQ scan that's suspicious for chronic thromboembolic disease, or I should say chronic thromboembolic pulmonary hypertension, we have a low threshold for proceeding to an invasive pulmonary angiogram at the time of the right heart cath. But you know, these are all so unique challenges, especially in this disease space, because essentially awareness for this disease is the biggest challenge. A lot of those, you know, who review these pre-authorization calls and these consults aren't even aware that pulmonary embolism is not a one and done disease. It has chronic post-thrombotic complications. And that's the one message I think is so critical for our discussions today, is for everybody to understand that it's very, very important to see these patients in clinic, make sure they're getting anticoagulated, they are being so followed up for chronic complications, as Sarah, Jeff, and Annie highlighted so wonderfully.
And Scott or Sanjam, did you have any, my voice is getting worse as the night goes on, I apologize. Did you have any utilization, or do you approach this differently at your institutions?
So we do also do CT perfusion. However, I will agree that we haven't found the niche for it yet. I mean, we evaluate very similar to what Sarah outlined in the sense that once a patient is considered to be high risk, we proceed with a VQ scan, and if that's positive, then we'll proceed to right heart cath and pulmonary angiogram. My one question for Sarah is, for some of the centers that are sort of starting this out, you know, one challenge is, how do you determine what are the higher risk TTEs? Often you will not get a TR jet that's appropriate to give you a pulmonary artery systolic pressure, and even if you do, it might be incomplete or may underestimate the degree of pulmonary hypertension. And you know, how often are you saying, okay, well, I don't trust that, I'm going on to a right heart cath?
Yeah, that's tricky. I think, so the way that we've tried to, so one of the ways that we've tried to streamline capturing most of these patients has been that any patient who has high intermediate risk or high risk PE automatically gets follow-up in our PERT/pulmonary hypertension clinic. And so all of those patients are I think, higher risk than a low risk PE to develop these problems. And remind me what the second part of your question was. When the echo is indeterminate, how do we decide who we're going to cath?
Yeah.
So in that case, I do think there's utility to exercise testing in that case. So I think if we do a CPET and the CPET shows signs of pulmonary vascular disease, then I think it's certainly reasonable to proceed with a cath in that case. There are some patients who are so symptomatic and the echo is kind of indeterminate or unimpressive, but because of how symptomatic they are, I've gone ahead and done invasive exercise testing in that case, because I worry that we may do the baseline hemodynamics and they're going to be normal because their echo is, for the most part, looks normal. And those patients I want to challenge with some sort of provocative maneuver during the cath. or during the calf with exercise.
Scott, I feel you have probably the most experience with this.
Yeah, and Victor Moles, who's with us as well, has done quite a few of these. I agree with Sarah completely. I think, and we'll have a session on this coming up. You know, we don't know, at this point, we don't even know what we don't know about this condition, and exploring it by pushing patients with these various provocative maneuvers, I think is critical, and it's the future.
Well, we've kind of extended a little bit over, and I think my voice is going to not last 5 more minutes, but I want to thank everybody today who was speaking. A fantastic job. Thank you so much for those who attended and bared with us through our technical challenges and provided good discussion on the chat. The next meeting is going to be on March 16th. And thank you for your attendance today. And we hope you have a great rest of your night and evening.